Good afternoon, everybody, and welcome to our webinar on AVT. If we could just get the slide up, the first slide that has the QR code, because we would like you, whilst people are joining, to scan the code and give us some thoughts about what you think about, how you're feeling about AVT at the moment. So Jules, if we could just go back to the previous slide, please, that'd be brilliant. Thank you. So the slido.com QR code is down on the bottom on the right. If you can just scan that, that would be brilliant. So today we are with a lot of people who have signed up, but I am going to start promptly because I'm aware of time and we've got lots to cover. So again, welcome everybody. Good afternoon and welcome. So I'm Breda O'Brien and I'm delighted to be chairing the session today. I'm an independent consultant now, but I started my career as a nurse and I worked in many clinical, operational improvement and technology roles during my career. And I volunteered to help support future nurse, having attended Natasha's session at HET, where there was such energy in the room. So I'm hoping we can capitalise on that energy around how AVT needs to work for nurses today. So I'm sure you can't be unaware that that AI is being touted as the solution for everything, all our woes in the NHS at the moment. I'm an enthusiast about how we can improve both care delivery and the work lives of our staff using technology, but I also have a healthy degree of caution about how we do this. Because for me, this isn't just about the tech. That's moving faster than we can consume. That's not the big challenge. And that's not to say the tech needs to meet all the regulatory requirements and safety checks. And we'll hear more about that today. And it could even be a subject for a deeper dive on a future session. But for me, the big challenge is how do we get the people and process right to enable us to really optimize the opportunity AI and specifically AVT offers. And ambient voice technology. I realise I've made an error and I've used an acronym from the outset. So ambient voice technology. And Atif will actually describe what we mean by that when he starts to speak. But getting this right will also help the tech to evolve in the right way. So we, as users, can be more intelligent partners working with our supplier colleagues if we can better clarify how we want and need the tech to evolve. So any of you who've joined today and are already involved with AVT will know that there are lots of conversations on the risks as well as the benefits. And it's important we address all those risks so we get this right. But I really feel we mustn't do that through the framing of doing nothing until we get things perfect. It's really important that we don't allow the AVT agenda to move forward in the health and care sector without a strong nursing voice. So I would encourage you to be in the centre of the conversations around this in your local organisations. And some of what we'll hear today demonstrates the importance of finding a way to test and iterate to get this right, rather than doing nothing until we get things perfect. So working with your improvement teams, bringing in that learning about how to test and iterate to improve things. If I can just ask people to go on mute, that would be great, thanks. So today's focus, as I said, is on ambient voice technology. Whether you're joining today as a novice to this, and we'll have a little bit of detail on who's in the room in a moment, a real enthusiast, a nurse currently using it, or a supplier, then I hope you get lots from today's conversation. I've had lots of conversations with nurses across the country in prep for today's session. And I got a lovely sense of this is that whilst a lot of people talk about AVT as technology and all about productivity, these conversations with nurses have reminded me that it goes to the heart, to the essence of nursing. If we get this right, it's about nurses being able to be fully present when dealing with patients or other colleagues, rather than trying to document at the same time. And it's not just nurses, actually, this is broad because we do need to work as MDTs, it needs to work for everybody. But it could enable us to deliver care that is more person-centred, or even caring for our colleagues. It's not just about patient-centred, person-centered interactions. So for me, this is really exciting, a really exciting time. So just about today, we've purposely used normal Teams rather than a specific webinar platform because this is about bringing the voice of nursing as a community together. And we felt it was important that you saw everything rather than us having conversations in the background. Because yes, we've got a great panel, but there's lots of expertise in this room about how we need to deliver care about AVT. So we wanted it to be an equal voice from everyone. And my colleagues Chris and Linda will be supporting in the chat and we'll post various links. But don't be too distracted by the chat because we will share the slides and the chat afterwards. But do see this as a chance to connect with like-minded people. Ask the questions that bother you. There's no such thing as a stupid question. And do share contact details if any of you want to connect with people you've heard speaking today or people who post something in the chat. As I said, don't get too distracted by it because we will share everything afterwards. We will pick up themes for questions and we promise to follow up on any questions that we don't get to answer in the outputs we share with you later. Do remember though, if you put your email in the chat, it will get shared with everyone, but I think that's the spirit of today. And I would say if people do share their emails, please use them respectfully. And then getting to the end before the beginning, we will send you a survey to complete with feedback. And I would encourage you to do this because this is really about a social movement around AVT for nurses. So your voice is really important. So we'd like to hear about what you liked and what might be different if we do some future events. And we also want to find out what you want from future sessions, as today is really just the start of a conversation. We've already got a sense that maybe regulation and safety might be a helpful session, but want to get your views. And we'll also need to think about links to other groups such as the AVT program, which I will provide some details on later, because we've had some really interesting conversations with the team there. And that's another group that you can join, and we need to work how we all work together. I'm just delighted there are some supplier colleagues on the session today, so thank you for joining. Please do remember that this is about focused on the people and processes. There's no supplier sponsorship or anything today. So please, a very warm welcome to you, and join the conversation, but please no product placement or sales related comments in the chat. So let's have a look at who's in the room. We have got a very good mixture of people in the room. So we've got a mixture of nursing roles from exec level to people on the ground. We've got quite a mixture of organisations, but this is a grouped up. So I know there's people from the charity sector as well. I know there's people from the armed forces. So welcome to anybody who doesn't see themselves reflected in that organisations. And then we've got a very mixed bag of people who feel, 24% of people feel they've got limited knowledge. So I hope today helps with that. And if there's anything that people talk about that you don't quite understand, do pop the questions in the chat. But we've also got, people who are currently using it, 69% or feel they're at the beginning of the journey, and 6.2% people describe themselves as experts. So a fabulous group to have a conversation on the subject. So that's enough from me. If we can go to the next slide, please, Julia, and get some feedback on how people currently feel about using AVT in practice. Would be great. Maybe we can come back to that if it's not working as the...
That slide is showing for me, Breed, so just
it's showing, yeah.
Okay, it's not showing for me, so maybe...
not showing for me either.
Okay. It's showing the slide, but not the results. Oh, here we go. Wonderful. I love the fact that the word that's in the middle is excited, because that's exactly how I feel. Cautiously optimistic. What a great, interested. There are some things. I love the fact that people say, I don't use it, but I think it's an excellent idea. So I'd love to think that today we can take people on the journey from it's an idea to how you might make this happen. And Peter and Catherine will share their experience, and Teef will talk about what they're doing nationally. So it's really, hopefully, you'll leave today feeling slightly differently than you did coming in. Enough for me. Going to introduce Teef, Head of Product in the National Transformation Directorate, leading on AVT. take us through some of the national thinking and plans. And then Rod, who's the Deputy Director of Digital Transformation, will join on the panel. He's listening, but will join later in the panel. And I know both of them work closely with Helen, our national CNIO. And I have to say, when I approach them to speak, they're very eager to join and hear the nursing voice. So Tiff, over to you.
Thank you very much, Breed. Nice to connect with all of you who I've not spoken to. So I'm Atif Ahmed, as Breed sort of described, and I'm currently the product lead for our safe scaling and adoption focused activities around AVT, ambient voice technology, and we're working hard in the centre to try and enable and create and support an environment that helps all care settings safely but effectively adopt the power of AVT. And then also trying to understand what we want to do from a national perspective centrally in terms of supporting and enabling that. What do we want to do once well centrally versus what should be done more regionally and more locally as we sort of work in that national, local, regional model. If you could go to the next slide, please, Jules. I'll talk about just a bit of an overview, kind of AVT. So assuming that whilst many people have heard of it, obviously it is also there from a national policy thinking perspective as well. It's conscious that I'll sort of spend more time talking about where we're up to with it, but here you can see obviously it's been articulated in the 10-year health plan at a national level, and then also was further articulated in the medium-term planning framework guidance and announcement. And it is really all about that desire to use this technology to really enable improved and transformed healthcare experiences across the care settings. And as Bree touched on, actually, in terms of benefit, it's we're not thinking just about efficiency or productivity here. We hope that it will have a multifaceted set of benefits that will be, both helpful from our colleagues' perspective, workforce perspective, and of course, most importantly, for the people we serve from a patient's perspective as well. If you wouldn't mind going to the next slide, please, Jules. And so just I'll touch on this very briefly. In terms of what ambient voice is, it's a technology that captures that sort of clinician or clinical staff patient conversation, and it then uses AI to generate both a real-time transcription and a clinical summarization of that, which can then, of course, help support in the documents and the note-taking creation and all the activities that sit around that as well. We think it will both be something that we want to develop over time as it gets more impactful, but also it's something that we think will have meaningful impacts across these core areas of, hopefully delivers an integrated workforce experience. So, really helping to power workflows, both through that note-taking capability in the first instances as we're at the beginning of this type of technology, and then potentially enabling future types of activity and automation as we get more advanced with the technology. Certainly really looking to transform that delivery of care and patient experience, making sure that the burden and the reduction is there from a clinician's perspective, but also making sure that then results in a improved patient experience around presence. Again, as Breed mentioned, your presence and being able to maintain, kind of real direct patient-facing care with a reduced burden on trying to also capture what's being said, so we can kind of flip that focus of care into more patient-focused. And then finally, looking to try and evolve this and scale this into more than just the AVT. I think it will become one of those foundational capabilities that enables much more intelligent activity that is powered both by AI and more traditional technologies in the future, really looking to streamline the burden and the administration activities, and freeing clinicians and care staff up to do what they love to do and what they tell us they love to do and what they're trained to do, which is that direct patient care. Again, Jules, if we could move on to the next slide, please. And in terms of the benefits or the areas that we really think this will have an impact on us is kind of from a national perspective, we've been considering these various spaces. So obviously we're always looking at technology to both improve, but also handle some of those most pressing problem areas or needs or challenges that we want to try and address. And we're aware of things around the waiting times, elective recovery, getting that access into primary care and those appointments, and hopefully helping to try and reduce workforce pressure and burdens as well. And then those benefits, we kind of the ones we've talked about are reduce that burden, which hopefully then increases you know, both clinician satisfaction, so can we reduce their cognitive load and the burnout challenges that they sometimes face, but also can we really improve that patient experience? One byproduct of that may be, you know, an increase in productivity, so more patients can be seen. Another byproduct of that could be, you know, actually allowing more time for example, slightly longer appointments where needed to allow for that deeper care. So I think what we're hoping to do is to provide both optionality and choice as we start to improve some of these areas around the time that's freed up, the capacity that's generated, allowing us to try and do more with the same, and or to give more choice around where that time is spent. And obviously we would expect to see you know, impact in some of the capacity spaces. It might result in some additional appointments, but that's not the only focus. It should also result in that deeper care opportunity and clinicians being able to spend more time in that direct conversation, pick up those things in more detail as they need to, and hopefully help our clinicians with that kind of huge multitasking activity that they sometimes need to do, and reduce that cognitive load so that they can stay focused on what they want to stay focused on. Right, in terms of background and context, that's where we're up to. But let's just talk about where. Sorry, yeah, thank you, Jules. Next slide. In terms of where we're up to date nationally and how we've been approaching this, and again, very much trying to operate in this sort of rapid test and learn methodology, where you know, I think AVT is a technology that is both in demand from the workforce. You know, it's kind of bottom up demand. We're aware of lots of clinical staff and clinicians using it and wanting to use it. And of course, as you've seen from the first slide, a real top level desire as well to drive this at a, you know, kind of national and policy level. It's obviously in the 10-year health plan as well. So we've tried to support this through iteration and through rapid iteration, because of course, as Bree mentioned, technology is moving at pace. So we're trying to work in a way that is both agile and iterative to try and stay aligned with it, but also try and get some value of support out there. And so what we've done is really these major things are, we've got guidance out there initially. We knew obviously this was something that was getting bigger, so we've released national guidance around what to consider and how we safely do this, how we safely adopt it. Then the other thing we've done is we codified that in November into a set of national standards around what expectations and capabilities that we want to expect to see from suppliers who are providing this solution, and also what we expect local commissioning teams to think about when they're looking to try and procure and use this solution in their space. And then finally, what we've done is codified that into a AVT registry, a self-certified national registry that is currently open to suppliers who are applying to come into that, and it's going through the review processes. And we're then looking to, in early January, publish our first list of AVT registry members. So folks, suppliers who have applied to that, gone through the review process and have met those criteria that we stipulated in that national model. And I won't go into the detail of that too precisely given time here, but really what we're trying to do here is help answer the question that we get asked as a national team all the time. You know, actually, can you just tell me what's a safe supplier to use or a safe technology to use? Well, this is part way in terms of helping you locally get that answer. So we're looking to accelerate and enable the local assurance and procurement activities of these things through a filtered, nationally curated lists through the AVT registry, which has, you know, evidence packs and standardization available. And also the benefit to suppliers is we hope to reduce duplication of effort by them being able to be on the registry in one space and making that information available to organizations as they look to go down that journey. And then to finish off, aware of time, that we will, from a phase 2 perspective, then start to look at more strategic solutions as we then move beyond the first phase of support of registry, moving into what does a national support element look like here. And we're at the very beginning of that conversation, so we were really keen to join here to try and understand what would be interesting and important from a nursing community perspective as well, and not looking at this through one lens, because we are operating across care settings and across clinical settings as well here. Let me stop there and pass back over to Bree.
Thank you so much, Tim. Well done on the time. I thought as soon as I appear back on, I feel like the baddie. And I'm sure it'll generate lots of questions. So please, to the attendees, please pop your questions in the chat so Atif can have a look at them as we go through as well for when we get to Q&A. Delighted. And actually, I thought, you know, what you've said, Atif, it all makes sense to me, because we do not want to duplicate. We need the centre to do the things that need to be done once to make life easier on the ground. So it sounds like we're in the right direction, but colleagues might challenge on that. So now over to Peter White. Pete, is the Chief Nursing Information Officer at Alder Hey Children's Hospital, and he's going to talk about demand-led change and their experience today. So over to you, Pete.
Thank you so much, and hello everyone. It's great to be here to talk with everybody. Yes, I'm Peter White. I'm the Chief Nursing Information Officer here at Alder Hey in Liverpool. If you could just go on to the next slide, please. Thank you. So I just wanted to cover basically our background with ambient voice technology. It's been fairly hectic, really, but over the last 18 months, we had an initial pilot in October 2024, 50 users, mostly with our CXIO team, and we've this is one of the rarest things in digital, is a project where you are being hammered at the door to have this technology released to you, and really battling people back to say, no, we want to do this properly, we need to make sure that it's safe. We had a specialist development in the December this time last year, seems like a very long time ago now, but the main sort of driver was obviously we had the rollout across kind of January to August, and as the chief mentioned, we had the guidance not come out till May this year, so we were trying to do things safely but also be able to do things at pace, and the sort of broader guidelines have been increased as we've gone along, and we've been really fortunate with our solution that we've had the MHRA certifications, stage 2 certification on the product, and we've done a lot of work for integration as well. That's part of the wide thing. So next slide, please. The ambient voice technology, it's used across the organization, mostly in outpatient clinics, and we've had some of our specialist nurses have been using it for telephone consultations as well, which has been really important and been fantastic to see that uptake, and people really exploring the new ways of using the technology, and improving the conversation and workflow. We've had a number of staff say that it has really helped them remind them of bits of a conversation that might not necessarily be in the front of your mind, but it also has been able to sort of beef out that narrative. And particularly in nursing, it's often quite challenging when you're trying to remember, particularly a long consultation, to be able to pull out those sort of important parts. We have the solution developed so that it brings it into a structured format, and that again helps that standardization and ensures that the clinics run smoothly and hasn't been any issues there. We've had the documentation predominantly designed for clinicians, but we've also got a separate standardized note for nursing and AHPs for some of the specific clinics they use, and again really well received, and we are currently exploring multidisciplinary team meetings, because that is going to be the biggest game changer when it comes to this, because we often have several clinicians and specialists from different areas all working together, and as you know you'll find that when you're working as a part of a team, sometimes when you're all on say Teams as a system, it works really well, but when you're in a room or when you've got hybrid kind of meetings, it can be quite challenging to manage that. Next slide, please. So I just wanted to touch on some of the benefits, and the main thing is obviously it reduces the documentation burden for the end user, but actually the children and young people really enjoy the fact that there is better engagement between the clinical person and them, and obviously at the moment we have often a screen in the middle. It'll often be somebody typing on their computer, writing up notes. That all goes when you've got ambient voice, and you can have a more natural conversation, you can work through things. We have done surveys with our children and young people. We have what's called a quality ward round, and what that is senior nurses go around and interview loads of children, young people and families, and of those surveyed, of the 72, they felt very comfortable with the AI solution being within the trust and being used, and the fact that the letters and the information is more richer and easy to interpret. We've also done a separate survey about when we've had 2 letters, and we've managed to coerce one of our neurosurgeons to write a load of letters, and be able to compare and contrast. And again, of those surveyed, 85% preferred the AVT one, and the clinicians also quite like that they can get more out of them as well. So it's been really well received, and it's great that we've got that there. Next slide, please. And so the future focus for AVT really is, for the ambient voice technology, is about the clinical safety. and it really is about how do we improve our ability within digital clinical specialism to be able to ensure these systems are safe. How do we know where the voice control has been processed? How do we know what models it's learning on? How do we know what data it's producing, storing? Some of the outputs that are coming out, we need to make sure that they are safe, but we also have to factor in the ethical and legal aspects of that as well. And so part of our AI or artificial intelligence board is joining that together, the digital, the ethical and the legal. More personalised paediatric care, and we're really focused on that within Alder Hey. We're really passionate about making sure that they are as digitally enabled as possible, and then the digital confidence within the organisation generally, but also using these AVT tools. We need to make sure that when we are deploying them, that they are safe, but also that they are really well utilised. Next slide, please. Just on the kind of final slide, I just want to make sure that everybody's aware that we do have an AI strategy that we launched earlier this year. It'd be great to get your feedback. Feel free to have a look at that. You can really see exactly what the route is for our children and young people, and the plan is that we're wanting to use this as a springboard for a future artificial intelligence work, but we're really passionate about working in this space and collaborating with others. Next slide, please. I think that's it. Yeah, fantastic. And just a quick shout out to Victoria Furphy. Vicky Furphy is our Chief Clinical Information Officer for Community Mental Health, and is also our lead for ambient voice technology within the Trust, and is a real advocate for this, both in the Northwest, but also in paediatrics. So got both of our emails there, and thank you very much. Back over to you.
Thanks, Peter. And thank you for acting in the spirit of a community by sharing your strategy, because I think that's what people really need. No one should feel they have to start from. I have always use the term pinch with pride and acknowledge, because again, we've got to reduce duplication of effort. So thank you. So next slide, over to Catherine Davis. Catherine's the lead nurse in digital in Wye Valley NHS Trust, and is going to talk to us about some different uses of AVT, and I think you'll find very interesting.
So thank you, Reid. If we can just go to the next slide, this just covers what we hope to cover in the next few slides with you. So next one, please. Yes, so we're Wye Valley NHS Trust. We are a small acute and community trust tucked away in the southwest bit of the West Midlands. And as you'll see, we also 20% of our patients also come from Powys, so we serve a proportion of Mid Wales. The picture of the sheep, we care for everybody in our community, and one of our district nurses saw that the sheep was lost and actually just popped it in her car and dropped them off on the farm. So it is one from a couple of years ago. So that's how embedded our teams are. So if we can go on to the next slide, please. So back in early 2025, our clinicians started to use AVT off their own back. So very similar to Peter, started to use it for their own clinics, etc. At the time, our managing director was really keen on not suppressing that clinical engagement and that clinical enthusiasm. We've never seen anything like it in the digital field. And so supported a trial use across the organisation in May. I have to say it was a bit different this time. The overarching project was very governance light, and for some people caused a little bit of concern because it was not how we would normally do a digital project. There were guidance which was IG and supported by our clinical safety officers, but for some people that made them quite easy. One of my colleagues described it as being a controlled explosion because everybody wanted to use it, very similar to what Peter's described. And I was actually challenged by the then managing director to see what we could do for nursing. The current position is that we've had that big blast across the organisation in all areas with varying degrees of success or enthusiasm. And we're now bringing that into more of a project management and focusing on certain areas where we can get those benefits. If I can have the next slide, please. So back in the summer, all ward sisters and matrons across the organisation had access to AVT. But when we were going around our team talking to people, we found that there was little appetite for bedside use, very much around that feeling of the noise that would be there, and some of those conversations that nurses will be having with patients and families. In July 25, we had a rapid improvement week as part of our digital work, and we observed that Lindsay, who's hopefully on this call, was using it for her appraisals. So the basic process was that she was using AVT to listen to the appraisal conversation. That then created the record of that conversation. Then it was transcribed, reviewed, and then copied and pasted into our trust documentation templates. So at the moment, there is no integration. Our various other systems still remain separate. Can I have the next slide, please? So at the same time, we're really lucky we have a benefits manager within our team. So Andrea went and spent some time with Lindsay and did some monitoring on what the benefits were. And we reckon, and this is a conservative estimate, that we probably are saving between 3/4 of an hour to 55 minutes per appraisal. And you'll see the quote from Lindsay below. If I can go on to the next slide, please. So basically, the benefits of it weren't just about the time that was saved. You'll see from this, as Lindsay said, she struggles with spelling because of her dyslexia, and she found this really beneficial. But she also found that being able to concentrate on the person in front of them and have that conversation without being interrupted or having to concentrate on taking notes was a real benefit. And I think we've all been, when we've either appraised or been part of appraisals, you know, things are talked about and sometimes they're not always accurately recorded or as you remember. So that for Lindsay was a real benefit. So if we go on to the next one, I think the other thing that probably is worth saying is because it is a real-time capture, we found that the records are there, they're actually, and therefore it will be easier to identify and go back to at a later date. We found that those records were factual, they weren't based on the memory or opinion. But the very important thing is no matter how you conduct your appraisal, there will be some degree of bias or maybe filters that are in. Actually, this has just heard the conversation as it's been said, so it is equitable and transparent. And I know that I think Lindsay's reflection on doing some that might be a little bit more challenging than usual, that was a real benefit. And seeing that conversation in black and white was beneficial to the individual. Certainly more time on focusing, and again, no lost paperwork. Well, I think all of us who, when you're trying to visit your appraisals around running a busy department, think, and I know that Lindsay has taken further work to structure her records accordingly so that makes it easy to do. So we can go on to the next one, please. So currently where we are, what we found was that certainly for the acute medical unit, which is the department that Lindsay manages, for around 50 staff, we reckon saved around 37.5 hours a year. And that's just by using it for appraisals. There are other opportunities, and I know Lindsay in her area has actually used it for those, such as return to works and sickness, team huddles, meetings. For us trust-wide, the current position with our nursing colleagues is that some are using it, some aren't. And there is a degree of nervousness for some. So certainly those of us who are working within a clinical systems group is to develop that how-to guide and support that roll out and embedding across the organisation. And as you will see, from Lindsay's comments, she feels that this is just added to her role, and as she kept saying to me, she'll tell everybody about it. So there we are.
Wonderful, thanks, Catherine. Josie, we could just take the slides down now, and I'll just invite the panel. I'm just so taken by what you've just said. Just going back to my time, often writing up appraisals was what I did after work, or it meant I went home late because I'd had a whole day of operational things that I had to deal with at the time. So imagine how fabulous this would be for our workforce if we could give them the ability to go home on time. And it just feels, these are really important use cases, aren't they? So if I could get Rod, we've got a T, we've got Catherine and Peter. I'm going to ask you a couple of questions just to get the conversation, and then we'll go to Q&A from the chat. So please put your questions in the chat. I can see there's quite a few coming in. So Atif, you've now listened to 2 presentations from nurses, and having said, you wanted to engage with the wider community, have you heard anything today, and Rod, who is somewhere on the call, have you heard anything new today that you think, gosh, maybe we need to do something different nationally or think slightly differently? And then Catherine and Peter, if I can come to you and say, you heard from Atif today, actually, are there any gaps in what he's saying, or is there some things you'd like national to do more of, or indeed less of, bearing in mind this effort to try and reduce duplication of effort for everybody? So if I can go to national colleagues first, and then come back to Catherine and Pete.
Thank you, Breed. And I guess my first reflection actually is it's wonderful and reassuring to see that a lot of the areas that we're trying to cover in our thinking and are looking to address with the kind of the national registry and then further follow-on activity is being kind of almost proven and reflected in what Catherine and Peter have talked about as well. There's a real desire for the technology from top and bottom. The benefits that Catherine talked about in terms of time saving is brilliant. The really interesting thing for me actually that I hadn't maybe considered is we'd always been looking at this through the patient workflow, clinical workflow elements. We always knew it would have benefits in a general administrative sense as well. So really fascinating to see the example there of the AVT being used for appraisals in terms of an actual line management duty perspective that is completely separated from actual clinical workflow or clinical and patient-driven activity. So I think that's a really interesting side of things that we had thought about as a general point, but maybe hadn't realized there was that kind of real adoption happening there. And I guess interesting that appraisal is made more effective because it's a medically trained AVT rather than just using standard technology that's existed for many years in terms of transcription and voice recording that maybe doesn't give as good a result as the medically trained AVT and its ability to understand the context of what's being said there. So I think that was a really interesting insight for us.
Hi, Breed. Sorry, I was late to the call. Rod Joyce, Deputy Director.
Welcome, Rod.
Just like to quickly introduce myself. Rod Joyce, Deputy Director of Digital Transformation, responsible for the AVT work. You're very safe in Atif's hands, have been so far. The only thing I was going to say was there's the calls I've had today already around how do you pitch AVT as a use case, and around it is very clear in the system. This is, I think I'm probably repeating, but it's very clear that this is about people. And it's about supporting people, both the workforce and our patients. And I think that's kind of the most critical part, is that this is a technology, some people have called it like a unicorn technology, that both the system and our frontline clinicians want, but actually also our execs and our ministers are actually also keen and supporting, which is very rare the two shall meet. So it's a real opportunity that we have now. But I think it's just fascinating that, we looked at it first from a primary care perspective in general practice. And we've tried to create a general use case around the clinical consultation, but it just shows that there are different use cases that actually add value across the whole system, whether that's in hospital rounds, whether that's in outpatients, whether that's in our neighborhood teams who are visiting homes. Each of them have slightly different capabilities, but that's the bit that we're really keen to understand is how do we build those use cases? How do we put a wrapper around it to make sure they're safe, they're effective and can be used? And actually, what is our challenge? Is our challenge more around get these things to interoperate, point-to-point data, so we actually can really realize the benefit? And once we do all those things, the productivity challenge will be addressed because we have a better flowing system. We have better data sitting in our EPRs. We have better opportunity to do probabilistic triage in the future on better, more rich data. And all those things, faster discharge, all those things actually will start to flow. We think we're now ready to be able to start deploying these things at scale.
Brilliant, thanks. Should we go Peter and then Catherine? Just any thoughts on what you've heard in the presentation or what you've heard from colleagues? And just picking up, there are a few questions in the chat around, the data structure, about the LLM, and about some, can national team do more around clinical safety assessments of suppliers. So really interested to get your collective views, but we can go to Peter and Catherine, and then I'll come back to national colleagues to respond.
Yeah, I think for me, the main thing is really clear guidance on the use of ambient voice technology and AI tools in the clinical setting. A review, so for clinical safety for all of our technology has to go through a DCB 0129 process, which is the supplier, and then DCB 0160 process, and a full clinical safety, hazard workshops, etc., has to be undertaken, and really clear guidance is what is missing there. I think the other thing from the national team, which would be great, is the putting pressure back onto the suppliers for the integration and interoperability, because I know in silos we are trying that, but I think for the tools to be really truly effective, that's what we need to get to. And we've been, you know, very fortunate in our case, but that's not the lived experience for many. So I think those are the couple of things, but I'm sure Catherine's got others as well.
I think mine are very similar to yours, actually, Peter. I think the first thing is being really clear on our expectations of that clinical safety, whether that be staff or individual patients. So that guidance that for CSOs and other people involved are really clear on what the expectations is, and for those staff who may have concerns, that there is assurance and they are assured, and that there is evidence to support that. And I think the other thing is about interoperability, but we say that about nearly all of our systems, don't we? And we have about 3 or 4 main systems, and you know there is still the problem of this junction between the two. But certainly in terms of any procurement now, it is something that we would ask to be part of that case.
Great, thanks. And Rod, anything you
Well,
want
do
to
you want to just come back on? So we are due to publish some IG guidance in the not too distant future that'll actually address some of those questions and some of the questions that still remain in the chat around consent, the use of data, storage, etc. So we're due to publish that early in the new year. So hopefully that will be clear, and we'll make sure that actually gets circulated to everybody who's attending. What we haven't done in that is the use of data yet as part of research and training of LLMs. We think we want to separate those two things. So it's around consent and patient experience first, and then moving into the slightly more knottier challenges. And then the integration piece, yes, is exactly the challenge we're working on. We know in, for example, general practice, through IM1 into those EPRs, we actually have a control mechanism that we can do point-to-point data solution. We know in secondary care, outpatient care, community, mental health, everything is a little bit more challenging. But the way we need to address it is by not talking about interoperability in point-to-point data solutions. It's through effective commissioning, I think, is one of our options, to be able to say, these are the people we commission, this is how we're going to do it. And we need to deliver that in partnership. We need to do it in partnership between national, between regions, between places, between our ALBs in the MHRA and NIHR and NICE. But the supplier market needs to be part of that partnership and accountable and responsible for delivering the value and delivering the accountability. Otherwise, we'll do that part, and then we have this separate part again. Because if we don't do that, all we're going to do is deploy licenses again. And if we don't put that change management training wrapper around it, the post-market surveillance, the performance monitoring, that's the wrapper that we need to put around this to make sure it's effective. We're trying to scale a minimum class 1 technology to the front line en masse for the first time. We know that's a real challenge. So I think that partnership piece is absolutely critical for us to be able to do that.
Thanks, Rod. There's a question just that's just come in, which is around interoperability, and it's around this is not just about the AVT suppliers, is it? It's about the EPRs, because we know traditionally that's been a challenge. That often some of the smaller supplier community are eager to interoperability, but there are barriers from the bigger players. So is there any? I mean, there's a question that is.
Yes, it's the easy answer. It's both the easy and the hard answer. As I said, primary care is a little bit different because of, we have 2 primaries and a third entering that space. And it's easier for us to be able to manage that integration. Secondary is a bit more tricky. So we are working through that at the moment. Now, we can easily get lost in sort of the architecture, infrastructure type conversations and talking about the future as opposed to the now, about what the architecture of the NHS needs to be. And we're moving towards that. But there is still real challenge about the delivery of now. So we're working on that very regularly. The point of this isn't about a siloed program. this is a program that cuts across our frontline productivity program, cuts across our clinical teams, cuts across our patient-facing teams. This is the one that sort of sits in the middle, and we're trying to do things as we head towards the 10-year plan delivery capabilities, the medium-term planning framework capabilities. That's what we've got at the heart of this, is to be able to say we're not siloed. We're looking at all these options.
Brilliant. And Peter and Catherine, there's some questions, and I don't want us to go down a rabbit hole here because I have experience of this conversation quite a lot, but about the need for, to get interoperability or connectivity, you need data structure, you need data standards. So there is a question, and I think a challenge to nursing generally about, what do we need to do in preparation? And I would go back to the point I made at the beginning. I don't think we do nothing whilst we're getting there, but recognizing for some of the deeper benefits, we will have to do something. But if you guys have a view on that.
Absolutely, yeah. So I think I know Helen Bolson, the National CNIO team, put out documentation standards, I believe last year, but I think more of that kind of structured work would really help. I think part of the challenge with particularly ambient voice is that it relies on there being a bit of a conversation there. It can probably do stuff from 5 to 10 minutes, but it does need a bit more than that. And a lot of the nursing workflow is quite quick and transactional. Now, where it would be really good is for admissions and discharges, and for the kind of more conversation type pieces, but again, we need to have that structure within that. But at some point we will get to a point where you can say, sort of snippets of things, but again, it then feeds into the surveillance and the paranoia for certain patient groups, whereby they feel that they're always being monitored. So we have to balance that very carefully, particularly in mental health, but in all areas we have to be quite careful that we're not just throwing this technology out there. But to answer the question directly, structured data is there, and I think we need to listen to that to have our systems set up so that it can be consistent. That would then really help the interoperability, because if everybody's already got the same structure, doesn't matter what system you're on, you'll be able to slot into that, and then you'll set me up on SNOMED coding and things. So I'll pause there so Catherine can.
That's where I've been in the past, so hence I was sort of saying, let's Catherine.
Me being involved in this area started with trying to sort our nursing documentation out. And even if an organisation like us, we can't get it right, I think our biggest challenge is for nursing to agree what data is included and what isn't. So what is essential and what's nice to have, really. So that feels an even bigger nut to try and crack. Agreed that it was really good to see the standards out. So it's how that follows on. Certainly our use of this technology has really only been as an adjunct, as a supportive to, like I've told Lindsay's story, to supporting frontline, or like Peter has described, use in outpatients. However, there are individuals who are testing it in other areas, and we will need to look at that. I certainly know that some of our AHP colleagues and community colleagues are using it out in community settings, using it to say do an assessment whilst being mobile and active with the patient, maybe. So collecting that conversation, so it means that those notes and what have you and that assessment is automatically written up. But at each point you do need professional judgment, because it may well have heard it, but equally the language or the thing so you still need that sense check. That professional sense check can't be left out of this.
Yeah, I think that's an important point, isn't it? That, because I know people have raised an issue that sometimes when they're actually writing the notes, they're reflecting and they remember what's important, and they're worried about this takes it away. But we're not taking away the fact that people have to validate the notes and make sure they've got everything, and that they've got. I know someone will probably mention hallucinations as an AVT term, that nothing has been included that isn't real, because of course this technology is evolving. But I would argue that it's probably no less imperfect than how we document now, because we haven't got it right, have we, completely? And this is a chance perhaps to really rethink. But there is and I know, Pete, you'll have a view on this. There is also a view about, how do we as nurses talk when we're trying, because it's easier in an outpatient setting where you've got more of a template to work from. But, how do you speak in a way that the AVT can pick up what's important?
I think that's really important. I sort of briefly talked on it, but not obviously. I think one of the trial use cases we're using at the moment is in critical care, and it's actually really useful for that environment. So we're using it for twofold: a nurse who's got dyslexia and really struggles documenting notes, really long notes, but also as a new nurse in that environment, it helps structure the way that she assesses a patient, and vocalizing that out is a really good way for her to be able to speak as she goes, and then when she's being assessed or being supported by educators. And I think we're going to have to see that across everybody. We're going to have to change our mindset to be vocalizing things a lot more, and that actually will help with the children, people, families, and service users understand what we're doing, because often we just crack on, don't we? We just get on and do.
Yeah.
Actually, if we were vocalizing more, we would then be able to sort of say, oh, actually, that is why I'm doing this, and I have to do this, and this is the outcome. And I think if we shift that mentality, somebody in the chat put about education, I think that's actually a really positive thing, because if you can articulate what you're doing for the benefit of the AVT and the notes, actually it helps the patient at the end of it.
Yeah, really important. And to take us down a little different path, and I think any of you can jump in here. Somebody has mentioned, and I'm delighted to see it because it's thinking about the future. What are we doing here around undergraduate education and preparing so that any of the MDT, not just nursing, but let's focus on nursing for now, are coming out with the skill set or understanding? Because we also need to know technology fails every now and then, so we don't want people to lose the ability to write things down. But how do we maximize and get that right? I don't know if anyone wants to come in.
Yeah, I think Brady, maybe just jumping in. So certainly part of our very, very kind of broad multidisciplinary squad that we have in our kind of scaling, safe scaling and adoption team is we have a permanent workforce education representative there. We have a person there who is absolutely focused on day in, day out around what are those core skills, what are those core activities that folks need to have in terms of skill sets they develop and skill sets they might need to maintain. So certainly we're aware of the thinking around the fact that actually kind of almost an over-reliance human, it's any human does it. It's, if I asked you to explain the last T's and C's you read when you agreed to use an app or some software, your muscle memory is kicked in, you've just hit accept on those T's and C's and you're using it. So definitely there's thinking in that workforce directorate space around training, skills, etc. around that. But then just building on Peter's point, actually also the fact that it can enable and reinforce the skills that teams and clinicians are learning, and that often they say if you can teach something back, you've really understood it. Actually, by vocalizing things as you're doing it, and we see a real benefit in patient experience there as well, because often, as my assumption as a non-clinician, but certainly as a digital expert, is that you will have an innate level of knowledge that you assume others may have, whereas actually then needing to maybe vocalize that in certain ways is not just beneficial for the transcription and the AVT software, but more beneficial for the patients in terms of understanding what's happening there. So I think there is that business change, implementation, and workforce thinking baked into what we're looking at as we look at the scaling and the broader strategic approach.
And just to build on that, because others may want to come in as well, there's a question about what training can we offer CSOs for this new, because I think that's an area, and there was an earlier point about what can the centre do in terms of clinical safety sign-off. So I think there's a big question around how do we support our clinical safety officers. But Pete, Catherine, is that your experience?
I mean, I'll jump in there. I think that's the biggest issue that we have at the moment. So I'm one of the deputy clinical safety officers. We have all of our chief clinical informatics team are clinical safety officers, and we're just trying to do with the best of with the knowledge we have at the moment, as you do in any situation. But I think some really clear guidance will be really helpful, and again I think that's part of the discussion we're having regionally and nationally about what is the right way to assess these tools. How can we make sure they are safe? How can we ensure that they do deliver what they say, and be able to offer that reciprocal support to other areas as well? Because I think that's it. But if we had that community of practice around it, it would be really useful. But yeah, it's really difficult. But I'm sure Catherine's got some experience as well.
I think I think are very similar to Peter, really. I mean, certainly our CSOs found how this was initially managed quite challenging, how that IG and that framework to allow this to work, because it was so different from how we've dealt with other things. And that was the challenge of how you took people along, because the actual technology was moving and that wish to work with it was, well, like we said, it was a controlled explosion. Like Peter said, people knocking at his door. You didn't want to stop that enthusiasm. I don't think we've ever launched anything digitally that has had this, clinical staff so enthusiastic, and that is part of the benefits that they're seeing in their day-to-day life. But in the same way as we wrote in paper notes not so long ago, we still need to treat it in the same way in terms of safety, checking that actually what's there is an accurate reflection.
Gosh, we could keep talking. Sorry.
And then how can we use the data to give us the evidence that actually it is beneficial, or it gives us that data that helps show people, demonstrate what the work of nursing is.
Absolutely. We could keep talking about this, couldn't we? Because it's such I was just working out in my head. I think I've been working in technology related to clinical care for over 30 years. This is the first time I've heard people really wanting that demand-led. So we really have a great opportunity if we can get, test, iterate, move forward, and really work with our supplier colleagues, work with, I think as evidence today, this is about partnerships at all levels, whether it's national and local, whether it's suppliers and customers, to get this right for our patients. So it's a very exciting opportunity. And on that note, if we can bring the slides back up, we will commit to answer the rest of the questions offline. So sorry if your question hasn't been answered, but we knew this was the start of a conversation. I do want to mention the AVT community that I mentioned earlier, which is sponsored by this institute at Cambridge University, which is a broad community to guide the future of ambient voice, and the details of how to join are on there. And colleagues, I think, may have joined from the AVT community today. So we will continue the conversations about how we work together. If we can go to the next slide, please. But 75% of you, and we had 277 people signed up. I know lots of people sign up so they can listen to the recording. But 75% of people have told us a specialist interest group would be helpful. So we're working on the basis that that is the way forward. And that needs to feed into AVID or any other, we want to work collectively. So we think more events on the subject, but we need your input into what you need more on. I mean, I think we've heard clinical safety and regulations a biggie, but there are other things. I think some people have got questions about community, for example, what's happening in community. Do we need to have a focus? Because sometimes the voice of community gets lost between primary and acute. So that might need a specific focus. So please, if this is a social movement for AVT and nursing, your voice needs to be very loud and very strong. So do feedback. We'll send out a survey. We'd love some volunteers to help shape and take some of this forward, because today, I had a conversation with Natasha saying, should we just try this? And boy, is there interest. So, please put your hand up to get involved. We're all volunteering to help. Possible face-to-face event, but actually possibly in April. Watch this space. Again, what would be of interest? What would make that useful? We don't want events for events' sake. And do stay in touch via Future Nurse. The website address is there. The hashtag follow along Future Nurse Community. There are podcasts every month. There's a newsletter. Can we use any of those to help with the AVT agenda? Please tell us what you'd like. And then the only thing I probably need to do now is to thank everybody who's been involved in the prep. Yes, mental health. Sorry, that's my bad. Definitely a mental health focus. To thank everybody who's been involved, our amazing panel. And Jules, Chris, Linda, who've been in the background helping, the comms team, Future Nurse, Natasha for her leadership and saying just go with this. And please, conversation, change happens one conversation at a time. So please, let's keep this conversation going, because that's how change happens. It's not the tech that makes the change, it's the people and the conversations around it. So thank you for joining. I hope you got something out of today. I certainly have. And please do when the survey comes out, please do complete it, because that's the only way we know what you want. So thank you, everybody. I'm keen we finished dead on time, but I'm a minute early, so I feel a bit remiss. We could have had another question, but enjoy lunch, everyone, when you get there.